Okay.
So
Now this is what happens. What do we do when you get no correction? You get no correction with normal plasma. So this is what we move forward to. And normally the main question that is, normally the main test that's elevated first, you'll have a normal pro time and an elevated PTT when they do their results. And the doctor will be concerned because they're not on an anticoagulant, and you got to then figure out what's triggering it. And I have you know too, lupus anticoagulant is part of a broader, and they put this in two different places in two different chapters in your book. They have an individual page that is in chapter 34, a single page, and then they hit it again in chapter 35 with all the next lecture, are hypercoagulable. But this is what happens. So there's a single page on page 712 if anybody wants to take a picture of it. Because this isn't an easy concept either. Okay? Coag is just tough theory. You're going to find that serology is tough theory. Some of the theories. Some people get blood bank really easy if they understand serology. That's why we put serology first. This is tough theory. You don't have a lot to relate to. So you got your, you run your normal plasma and it does not correct, and you know the patient isn't on Coumadin or heparin or any other anticoagulant. Then you got to suspect one of these two. Usually, they're not going to suspect a specific inhibitor unless they know they have Christmas disease or their hemophilia or hemophilia B or their hemophilia A. These poor people, you know, they can't catch a break, especially if you're hemophilia A. You're going to get a lot of blood source from a lot of different people, so you have the chance of getting AIDS. And here they're trying to give you a product to correct your insufficient factor VIII, and you develop an antibody to it. Inhibitor is an antibody to those specific factors. So, especially if you're a severe hemophiliac A or B, it's tough to treat you because you might develop an antibody or an inhibitor. So this is going to be a select group of patients. Usually they have hemophilia A or B that develop this. The lupus anticoagulant, you're going to hear it called the lupus inhibitor. You're going to hear it called the lupus anticoagulant. It doesn't only involve people with lupus. It was discovered with someone who had lupus developed this inhibitor. But other conditions, even people that are pregnant can develop a lupus inhibitor. So it doesn't mean, oh no, that it's only patients with lupus. It is one part of a group called antiphospholipid. Your PF3s, your what the platelet exposes at the release reaction is a phospholipid. So these inhibitors are antiphospholipid. Any place in either intrinsic or extrinsic that has a phospholipid is going to be affected. There's two PF3s, remember, in the intrinsic because you have it at 9A, 8 PF3 calcium, and you have it at 10A, 5 PF3 and calcium. Those are phospholipids. So that's ultimately, your ProTime is going to be elevated as well. The first one elevated, just like when you're on heparin, the first one elevated is the PTT. So that's how they first notice it. There's another antibody that's part of the anti-phospholipid that the chapter flags, is an anti-cardiolipin. I'm not going to make you know that one, but you'll hear about that when you do syphilis testing in serology. Sometimes people can have an abnormal syphilis test when it's the screening one, and it doesn't mean they have syphilis, but they have this cardiolipin, and they make an antibody to it. So this one is the hardest one to understand because it can be involved with many conditions, and you're not on any medication, So the doctor gets an elevated PTT and he has to figure out, why is this elevated? And the problem is with this one, it's also in our hypercoagulable chapter because the people can tend to thrombose. They don't have any problem with bleeding, but they, if anything, like factor 12, they can thrombose. So that one's the toughest of the two. So, it can be due to infections, drugs, other conditions. Lupus is a common condition, but it's not the only one. And one of the things they do, if they get an elevated PTT, let's say it's 45 seconds, and they'll say this is 12 seconds. There's an easy screening test you can do to decide if it's a specific factor inhibitor, like 8 or 9, or if it's a lupus inhibitor. How long do we incubate when we were doing the testing for PTTs? How long did we incubate the reagent for?
3 minutes.
On either machine. The first reagent. The first reagent, when you added it over here on this well, when you were doing the PTT, you did patient plasma.
Oh, 3
and
minutes, right? 2 or
3
3?
minutes. And the MLAs, the true procedure says 5 minutes, but we broke it down to 3 minutes once we saw the start 4 was 3 minutes when we got these machines, so we found that the PTTs worked fine. That is your normal incubation. What they find, if you take the patient plasma, it's a screening test any lab can do, even if they don't have the specific confirming test, plus PTT reagent, and instead of incubating it for 3 to 5 minutes, they incubate it 1 hour. Okay? And what they find, the lupus inhibitor affects any place you have a phospholipid, PF3, or the textbook sometimes just refers to them as phospholipids. They're one and the same. So we already discussed where the phospholipids are in your intrinsic or extrinsic. So what they have found, and then we know if you have a factor 8 inhibitor, what's going to be elevated? The PTT. It can't do its job. If you have a factor 9 inhibitor, what's going to be elevated? The PTT. So the commonality between if it's a lupus inhibitor or a specific inhibitor is that they both affect the intrinsic system first. The lupus inhibitor will ultimately affect the protime as well because you have 10A, 5, PF3, and calcium when you get to the common factors. But the PTT is first. So what they do, what they have seen, which will help the physician, especially if if it was someone, let's say through the ER, and they didn't know you were a hemophiliac, they incubate this PTT with the reagent 1 hour, and then add the calcium chloride. They find the people with the lupus anticoagulants, there is no change. The PTT stays 45 seconds. They find if you have a specific inhibitor, they get longer to act and stop, either 8 or 9. The PTT increases, so it might be like 80 seconds. So this right away tells the doctor if it was still 45 seconds after an hour, we don't have to worry about a specific inhibitor. We got to focus on the lupus inhibitor. And that's going to be the most common one that they wouldn't know about because most of the time you're going to say, I know you're a hemophilia A, I know you're a hemophilia B, I bet you have a specific factor inhibitor. And then they won't even bother to test for the lupus inhibitor. This is the one that you've got to know the two tests, at least what to confirm them for the registry. I'm not going to make you know specifics. I'm going to explain how they work, but for the test, you just got to know how would you confirm a lupus inhibitor, and it's going to be by these two tests. One is the DRVVT, and one is the PNP is this platelet neutralization. So you're just going to have to know, you confirm it, DRVVT, dilute Russell Viper venom test. And PNP is this platelet neutralization test. So those are the two that you confirm it with. So you've got to know, how does a lupus inhibitor, yes?
So you're saying that the change to 40 or the no change is what tells you that it's the lupus one.
That's your screening.
And the change in the specific is what you expect. That's normal.
You expect it to go higher because you've given that inhibitor a longer time to act on factor VIII,
Okay.
and they find the longer time doesn't make it any worse if you're going against the phospholipids. So that is a screening test every lab could do. You know, it didn't matter if what's it take to incubate it an hour? It's no extra reagents, no special reagents. So it's a screen, just like doing the fibrinogen when you have it's down to 1 in 5. Most labs will have fibrinogen, so it's no big deal to order a factor 1 in that case. And a lot of times that's your common abnormality is the elevated ProTime and PTT. So you're going to suspect 1, because it becomes the fibrin clot. So that's the easiest one, and that's why a lot of labs at least kept factor 1 assays. Okay, so that's something you got to be aware of. This is the screening test. Any lab can do this. If the doctor, he says, do a 50-50 mix, do a 50-50 mix with normal plasma. So that's the first step in your mixing study or substitution study. And you'll tell him, I did that and the PTT was still elevated. And he says, I know they're not on any heparin or Coumadin. There's no other physician treating them besides me. Then we're going to do an extra hour incubation on that PTT reagent, then add the calcium chloride. Then if it stays the same, he's going to suspect a lupus inhibitor. He's already ruled out they're not on a medication. He already knows it's not a clotting factor because it didn't correct with normal plasma. So then he starts thinking, and this is pretty common out there, this lupus inhibitor, especially more today than ever. So you want to be able to know what's going on, why their in vitro PTT is elevated. Remember, the ProTime and PTT are in vitro tests that are trying to mimic what your body is doing. And the key thing is the lupus anticoagulant affects any place in the cascade there's PF3. And there's 2 places in the intrinsic system. There's 1 place in the extrinsic, just when it's the common factor. So it's non-specific. So this is the example about what I gave you here. So there are 2 confirming tests. You don't have to explain the confirming test. You just have to know you use either dilute Russell Viper venom. What they do in this test, they give you a very dilute PTT. Because one of the other things, the PTT, a second thing the PTT reagent provides that I didn't make you know is a phospholipid source. Why would you have to add a PF3 or a platelet source in the PTT reagent? Where are all the platelets from the blue top? You spin it fast, so where are all the platelets?
They're gone.
In the buffy coat. So they're not in the plasma. They're down in the buffy coat. So do you have any platelets to provide a PF3? No. So the PTT provides, what's the first thing the PTT reagent provided? To mimic collagen, it had to provide an activator. The second thing now you learn is it provides PF3 or a phospholipid. So in this test, what they do is have you use a dilute PTT reagent. Just like we talked about in the hemostasis lab methods, the Russell Viper venom test, there's a reptilase test that I talked to you about that mimics, it's better than thrombin. You remember why it was not a good test, the thrombin time? Anybody remember what interferes that it's going to be abnormal? Heparin. So what they can use, remember, snake venoms are good clotting mechanisms. So a reptilase test is just like a thrombin time, but it's not affected by heparin. Well, this test is dilute Russell Viper venom test, so it's another snake product. And what they do, they don't have as much phospholipid in this DRVVT. So what do you think the lupus inhibitor will be stronger? So will it take longer to clot because it overwhelms the phospholipid easier because there's not as much? Or do you think it will be shorter and down to a normal PTT? If you don't have as much, that lupus anticoagulant should be able to even work better. So that PTT is going to be even higher. So the same patient whose PTT was 53 seconds, if you do the dilute PTT reagent, which in this case it's called DRVVT, it can act really easily and overwhelm that phospholipid, and you won't be able to clot. So it goes very high. So dilute Russell, if you maybe put it's a diluted PTT reagent behind it, the phospholipid antibody works better because it doesn't have as much to overcome because you don't have as much phospholipid or PF3 in this reagent. So you gotta understand there's two choices. I'm not even gonna make you explain that, oh, the PTT would go higher in that one and it'll go normal or better in the next one. You just gotta let me know DRVVT and PNP are the confirming test. Will each lab do both? No. They'll pick one. A special coag lab, I'm sure, is going to pick the one that confirms it the easiest and maybe is the easiest test that gives correct results. Some tests are hard. If you can't get all your techs to do it accurately, you're not going to choose that test. You want a test that every tech can do accurately with minimal struggles or training. Okay? So the DRVVT is one way they confirm it. And then the PNP is the second way. This one, they actually use a reagent that has more phospholipid in it. So if you have a lupus anticoagulant, you can't affect all the phospholipid that's present because they add higher amounts of PF3 and phospholipid. So you have a lupus inhibitor, it's going to act on any phospholipid, but there's so much, you're not going to make much of an effect on the PTT. So the PTT is shorter, maybe at least 10 seconds shorter. So you need to understand for the test that the PTT is elevated and they're not on any medication. You need to understand that the normal plasma did not correct it, so you know it's not a factor. You know you checked their drug history. They're not on heparin or Coumadin. You did the extra hour incubation as the screening test, and it did not change. So you're suspecting the lupus inhibitor. Now the doctor has to order, I need a confirming test. I'm either going to do the dilute PTT reagent, which is DRVVT, and the lupus anticoagulant is going to work better, and the PTT is worse. Or I'm going to say, I want to use a very high-leveled phospholipid PTT reagent, and then your PTT is not going to be inhibited much at all. So that you just need to be able to tell me the two, and you need to know those two for your registry. They have questions related to the lupus inhibitor, and it'll be the DRVVT or the PNP. So you at least got to be aware that that's confirming a lupus inhibitor. Okay? And on usually the specific factor inhibitors, they know they have hemophilia A or B. So the doctor is pretty darn sure if that PTT is elevated, that is because they're developing an antibody or an inhibitor to what they're giving them to treat. So it's a tough position for the patient because you don't want them bleeding out and bleeding profusely. And so unlike, does the lupus anticoagulant act on a specific factor? No, it acts on phospholipid. It doesn't touch factors. If it's a specific factor inhibitor, it usually is 8 or 9. That's the most common ones the book talks about. So if there's any way you can use a synthetic source of factor 8 or 9, something that maybe they won't make an antibody to, because in serology, immunology, you're going to learn your body does an inventory of what's normal for you. anything comes in that's abnormal, you're going to try to make an antibody to protect yourself. So that's what they're doing. These patients are getting sources, especially if it's human sources, and their body's going to say, wait a minute, I don't recognize that. I'm going to protect you, so I'm going to make an anti-factor 8. I'm going to make an anti-factor 9, depending on which one you have. So then you're up a creek. What do? I need the factor 8 or 9, or I'm going to bleed profusely. So the thing is, this one is more easy for the physician to know where to go when it doesn't correct with normal plasma, because he already knows they have a condition that commonly develops an inhibitor. Okay? And then this one, we know down here, when you did the extra hour incubation, the PTT got worse. That inhibitor said, great, I have more time. I'm going to act on all your 8 or all your 9. And the PTT got worse. And there's a test, one of the tests they recommend in the book, a confirming test is called the Bethesda Specific Inhibitor Assay. So you got to know 3 confirming tests. You don't have to know anything. To confirm a factor inhibitor, use a Bethesda Specific Inhibitor Assay. And there are multiple ones that they can do. And then to confirm a lupus inhibitor, you pick one or the other. The lab may choose to do the DRVVT and use a weak PTT reagent, or they can do the PNP and do a very strong, high amount of phospholipid. Okay, so get your worksheet back out. Now we'll go to the last problem so you have it correct. And then you have all the examples I'll give you. So your test on Tuesday is going to be over these 2 PowerPoints. We'll do the lab methods and the circulating anticoagulants. And then we'll do another test Thursday on the remaining PowerPoints. Then we'll have to come up with another final day, because I don't want to rush through stuff, because you need to understand it, and I'm sensing you're not understanding. I know it's a bad day to do lecture after a test, but everybody's looking like, oh my gosh. So it's pointless to rush through it, because then you're not gonna retain it. Because you gotta retain as we build to the final, and sometimes it's very discouraging when you're like, what? I don't get that. No, I don't remember that. And you're like, that's why we have to have comprehensives. If we didn't do comprehensives, I don't think anybody would pass the BOC, because you wouldn't say, well, I don't have to know it again, so why bother? So
there's no study guide due tomorrow.
Nothing's due tomorrow. I'm going to give you the rest of the study guides, but I'll just put up the 2 we did. So look at patient number 8. Now tell me what it could be. Oh, sorry. Got to change the video. So does everybody understand these were not need to run? Does everybody understand that? That you don't, if it doesn't correct with all the factors, why bother with 5 and 5? Okay? So not needed to run. There is no factor deficiency. So, what is your first thing you got to do if this happens? You're a tech and it does not correct with normal plasma. What's the first thing you think you're going to do and call the floor about and ask the nurse? Okay? The first thing you do when you get this scenario, and a lot of times they'll say, hey, I have this elevated proton in PTT or PTT. I need you to run a mixing study with your normal plasma. Just take 500, mix the tube, put it on the machine. If it doesn't correct, you know it's not a factor, because the normal plasma should have corrected it if it was a factor. That is the key step. And I've even seen registry questions say, what is the key step to doing a mixing study or substitution study? It's that one. The normal plasma starts you in the right direction. Okay, so then you call the nurse / physician. Any medications. So if they say yes, they're on heparin, you're done. That's the issue. That's why we thought the thrombin time was pointless unless the doctor did a test to remove heparin. Because half the patients in the hospital are on heparin when they come in, and if you're going to order a thrombin time and don't remove the heparin, you know it's abnormal, so it doesn't tell you anything. They were on heparin. Okay, so if no, then you proceed to 2. Is it a lupus anticoagulant or a specific factor inhibitor? Now what do you do? What did you just learn that you do that you can do in any lab? You don't have to have any special reagent.
Incubate it.
That's not, those are special tests, so you're not going to do that at the normal lab.
Incubate it.
Incubate what? For an hour. So you do the screening PTT. Incubate the PTT reagent plus plasma, patient plasma, for 1 hour instead of the 3 to 5 minutes. Then add calcium chloride. Okay? Every lab can do this. It doesn't take any more reagents. And remember, you just learned what's the second reagent in the PTT. You know it's an activator to mimic collagen to get 12. Now you know for this test you got to know the second one. The PTT reagent, if you want to write it on the side, has both an activator and it has extra PF3 or phospholipid. Because a lot of books just call them phospholipids. That's 3 to 5, I'm sorry. Because the Start 4 is doing 3 minutes, and so we started making our MLAs 3 minutes instead of 5. But the true procedure on the MLA was 5. Okay? Then, how do you know if it's a lupus? Which one? If the PTT, let's say the PTT was 50 seconds. If it's a lupus inhibitor in the screening test, what's it going to be after an hour incubation? 50 seconds. What's the specific factor inhibitor going to be?
8 or 9.
It'll work better, it'll be longer, so we'll say 80 seconds. So that is the screening test any lab can do for a normal plasma does not correct. You know, that's the key thing. The normal plasma didn't correct. You called the nurse or physician, they're not on heparin or Coumadin. You gotta look for something else. And a lot of times, like when we talk about hypercoagulable, the hypercoagulable is a lupus anticoagulant. So the doctor's not gonna worry about him bleeding, but they might thrombose. Yes?
I get how the lupus stays at 50, but what is the special factor
80.
inhibitor?
I got
okay.
80
Bumps
seconds.
to 80.
Sorry.
Okay.
My writing is not the, let me see if I can blow it up. So what you have to know is the screening. What do you do to prove it's not a factor? When you know it's not a factor deficiency, the PTT is elevated for, you know they're not on medication, and that's all on you. Because you can call the floor and check, and then you can do an extra incubation for the PTT reagent. Then what's the doctor going to have to do? If it's a lupus inhibitor, you've proven, because it stayed 50 seconds, what's the doctor going to order?
DRVVP.
DRVVT or his other choice? PNP. If it proves that the PTT after the hour incubation went to 80 seconds, he's probably got a patient with hemophilia A or B. Then what test can he order? That Bethesda. So that's all you got to know about the confirming. You don't have to tell me anything about him, but you do need to understand the screening. Okay, and we'll review tomorrow, so we'll go over this again. So what we do tomorrow will be on Thursday's lecture, and we may have to finish it up on Tuesday. So we'll come up, so Leah, you have the most classes, you let me know. Worst comes to worst, I can put yours, single one in the testing center. I can't go do a whole group in the testing center, they'd kill me again. And then we just, Alicia, I gotta see. Now, if anybody, so tonight what I'll do is I'll put up your, study guide key. And I'll tell you, there'll be ones flagged for the circulating anticoagulants, and I'll tell you which ones, because I think the first two go with hypercoagulable, and we won't have that till Thursday's test. So we'll still have 2 tests next week, but we'll just finish out the theory, and then we'll do the final on a different day. That we won't be so rushed. So, the substitution studies is a big part of your test, your next one, okay? So if you don't wanna stay and work with me, find someone of your fellow classmates that gets it. Do some of you feel like you get it?
Yeah.
So you wanna raise your hands if you really get it, so they at least see who gets it?
Usually tomorrow we can stay.
Yes, tomorrow I can stay with anybody again, but honestly, you need to get that. So whatever it takes to work with me extra, to work with someone who gets it as a classmate, you gotta know those, okay? So I will, tomorrow what we'll do is we'll continue on the lectures that we have left. We have 3 left, and then we'll review for the test, and we'll have that on Tuesday.